Okay, let's get started. Welcome everyone to this week's Journal Club. Thanks for coming. We're short a few of the heavy hitters, including Bubba. So like this may go off completely off the rails. And if it does, then I'll blame it on him. My name is Matt Compton. I am one of the occupational medicine residents. And the article I'm presenting today is called Heart Rate Variability and Performance of Commercial Airline Pilots During Flight Simulations. I picked this article because I'm interested in a couple of the different topics within it, including aviation in general. I was a flight surgeon before I came to this program, and worked a lot with pilots and flew with them, and kind of have an interest in that as a hobby as well. So that's something that interests me. In addition, at least half of my jobs in the Air Force have been sports medicine related and human performance related. And we talked a lot about heart rate variability. Even though I never did any studies or had any direct interaction with it, it was something that I knew about and kind of was familiar with and was interested in. In addition to those two reasons, I think it's probably an important topic because we know that probably 8 billion people will fly by commercial airline in the year 2035. That's double what it was in 2016. So it's growing, and it's a very visible form of transportation, even though it's one of the safest ways to travel that we know of. When something does happen, it's catastrophic and it's very visible, right? So the research on it is important because of that reason, in my opinion. The story goes that there's a surgeon who goes to see his doctor, and they're arguing over which profession has the higher stakes and which one has more responsibility and more difficulty with these types of things. And the surgeon went on and on about how he was operating on people every day, and lives were in his hands, and he had to make decisions that affected people on a daily basis. And the commercial airline pilot, just listened to him calmly. After he was done, he said, "Well, tell me this. In your worst case of malpractice, how many people will die?" Just one or two, right? If you're an OBGYN. And so that brought clarity to the surgeon that an airline pilot does have some responsibility there, even though it's a different technical skill. So the purpose of the study was to investigate how varying carbon dioxide levels, as well as how sympathetic response measured through heart rate variability, affect commercial airline pilots' ability to pass maneuvers on a simulator exam. Is actually a follow-up to a prior study that these same authors conducted a few years earlier. It was done out of Harvard. And the prior study was just investigating the carbon dioxide levels and how that affected pilot performance on difficult and semi-difficult maneuvers in a simulator. What they found was that pilots who were exposed to higher levels of carbon dioxide were 1.5 times more likely to fail those flight maneuvers. So this study expounded on that study and included heart rate variability in this mix. And they wanted to know if that affected pilots' ability to pass a flight maneuver, and then potentially the interaction between the carbon dioxide, the heart rate variability, and other fixed variables within the model. So what's heart rate variability? Well, in simple terms, it's the beat-to-beat variability of your heart, okay? In other words, the heart's not a metronome. It doesn't beat exactly the same time. And if your heart rate's 60 beats per minute, it's not evenly spaced throughout those 60 beats, right? It varies depending on a number of different factors. And what we have found out over the years is that it's a good indicator of how our autonomic nervous system is working. So if you remember back from physiology, undergrad or later on, the autonomic nervous system controls the two systems, the parasympathetic and the sympathetic. Sympathetic is the fight or flight. Parasympathetic is the rest and digest. That's how I learned it. And the heart rate variability is an interaction of that system. There's other things that factor into the model, but those two things are a main contributor to heart rate variability. What we know is that sympathetic or fight or flight response will tend to increase the heart rate and keep it steady. Well, parasympathetic inputs slow the heart rate and also cause some variability within the heart rate itself. And we found out that it's a physiologic indicator of stress. So low heart rate variability indicates stress, physiologic stress of some sort. How do we measure it? Well, this study used a couple of different well-established criteria, as well as one that's a little bit less well-established. The top one that you see right there, called this is on SDNN, standard deviation of the end-to-end interval. If you remember seeing EKGs, the big spike in the EKG is the R wave, if you didn't know that. And what it's saying is it's taking the standard deviation between those R wave variabilities. So the more those vary back and forth, that standard deviation is going to have the data more spread out and cause your heart rate variability to increase. They use N instead of R because N represents, they take some of the artifact out of the electrocardiogram. So, if someone has PVCs or just move an artifact, they'll remove that and they call it N to N for R to R. And the next one is, I think I haven't mistyped the root mean squared. It stands for something else, but it's not standard deviation, so I apologize for that. The root mean squared standard deviation, basically they take the successive deviation. So root mean squared of the successive deviation from the prior one. So you have one heartbeat, between heartbeat 1 and heartbeat 2, there's a difference, right? They take that number and they square it, and then they take between 2 and 3 and they square it, and they add those all up for a minute or so, and then they take the square root and take the mean of that. And it's more of a measure for parasympathetic response. So what we know is higher SDNN and higher RMSSD both mean better heart rate or higher heart rate variability. Okay, the bottom one, the low heart rate variability, also is divided into time domain and frequency domain. And I don't really capture like what exactly that means, but the frequency domains you can estimate with these low frequency and high frequency variables that you could then estimate the heart rate variability. What you need to know for this paper basically is the top two, if they go up, the heart rate variability goes up. The bottom one, if it goes down, the heart rate variability goes up. So it's an inverse relationship. Okay, that's it. We'll review it in a second. So optimal heart rate variability, we think, is associated with executive functioning and the ability to make frontal lobe decisions, right? So focus and memory, working memory, flexibility in decisions, things that make us human, basically, that emotions and things like that. The frontal lobe handles that, and we think heart rate variability has a very close association with our ability to do that. It's influenced by a lot of different things. We talked about the autonomic nervous system, but also the respiratory system, the vascular tone, the baroreceptor, if you remember those terms. And it varies with age, health status, sex, and heart rate itself. And it's also associated with higher aerobic fitness and executive functioning, like I talked about. This study used a crossover repeated measures design where they took 30 pilots and they had each of them in an Airbus 320 simulator undergo flight testing under different conditions. One of those conditions was carbon dioxide. So each pilot had 3 flights, and each flight he tested on a number of different, I think there's 15 or so flight maneuvers, and they needed another flight at a different CO2 concentration, and then the third one they did another flight with the same, or with an elevated CO2 concentration. And then those flights and the maneuvers were evaluated real-time by FAA examiners, and the pilots and the examiner were blinded to the conditions, and the order of these testings was randomized. So here's some basic information. You'll see that gender and ethnicity are not quite represented very well. Age and BMI are pretty, spread out evenly, but there were no females in the study. That is representative of the industry itself. There's 94% males in the airline pilot industry, but that is something to note. And then the ethnicity, interestingly, there were 74% Latino and then mixed within the other ethnicities. Okay, pilots were paired in teams of 2. Each team, as I just talked about earlier, they flew 1 flight at each carbon dioxide level, and they used these cylinders to fill the simulator with carbon dioxide, and they had a couple different monitors to make sure everything was perfect, and they controlled for the other environmental factors like humidity and temperature. Okay, every pilot flew each maneuver for each flight, and then the maneuvers were classified into difficulty levels of A, B, or C. I don't know for sure if these levels are something that has been standardized on like flight check exams for, because a pilot has to do a flight check exam or before they get their airline transport pilot license and periodically during their career. And I think they align pretty closely with those standards that they use in this study. Graded by 3 FAA examiners, and they wore a heart rate monitor that monitored those 3 terms we talked about. The statistics part of it, so they used multivariate linear models that analyzed the fixed influence of heart rate variability, like age, BMI, flight experience, and carbon dioxide conditions. And then they used what they call a generalized additive mixed effect model to talk about the variables, including the maneuver difficulty. I didn't grasp exactly, all the intricacies of a GAM model, but what I gathered was it's like a really complex and more capable linear regression model, where you can put multiple variables, and it doesn't necessarily have to be linear, and a couple other things that makes this a more complex but more useful model that you can use for studies like this. I'm not sure if there's a SAS model, but I'm sure somebody's cooked it somewhere. Okay, remember heart rate variability. Higher SDNN means higher heart rate variability. Same with the root mean squared of the successive differences. And low frequency to high frequency means higher heart rate variability. So heart rate variability trends here. Interestingly, one of the first things they noticed was that the heart rate variability of all the pilots was lower both before and during the maneuvers, during the simulators. By lower, I mean lower than the normative values that has been gathered and are pretty established. So what they propose that might be because, well, of course, during the simulators, you'd expect a little bit of elevated stress levels and a decreased heart rate variability in response to that. But before, you can see how that might be as well, because they're anticipating having to do an exam. This is something that they may have kind of a conditioned response to these exams too, because it's their career on the line. If they fail more than a few of these check rides, then it can mean that they have to take a pay cut, they have to get out of the career field in general. So even though this is a simulator, they knew they were in a study that they could have some sort of stress response before they went into it. So some general results, the measures of heart rate variability were lower for difficult maneuvers. So for the difficult maneuvers, the pilots had stress response, they had lower variability in their heart rate. And they measured that in one association with what they call the interquartile range. So they took the 2 middle quartiles and they averaged them out and saw what difference there was from their normative and baseline values. So what they found was the top 2, or the 2 established criteria for heart rate variability, showed an association with 37 and 22% increase in the odds of passing a maneuver. And the LH-HF ratio also showed a correlation with passing the maneuver for lower levels. And then some interesting things, the low frequency, high frequency values were quite close for most of the maneuvers. And that could indicate that there's sympathetic dominance, because those 2 values kind of tell us that there's sympathetic dominance in the heart rate. And then it was highest during the takeoff maneuvers. This graph just shows the maneuver classified by the difficulty. So I think, so the A is the least difficult, C is the most difficult. So the blue ones you see are more difficult. And in general, it trends towards being, if the maneuver was difficult, they had lower heart rate variability, but you do see some outliers. For example, you see a couple of difficult maneuvers at the highest heart rate variability. So that's interesting to note. And the other variables trended the same. So you had some kind of scattering of those higher difficulty maneuvers towards the higher heart rate variabilities, and then more of them towards the lower end. Okay, and then this was the LHF, so same trends. Associations, but not perfect, and it could be, and I'll talk a little bit about this later, but it could be low numbers, and there's only a certain number of maneuvers that they could do, and they're drawn from a pool of difficulty of maneuvers, and so lower numbers will maybe skew your data a little bit. They also noticed the heart rate variability were higher for younger pilots, and also it was lower for obese pilots. And lastly, they talked about how, because some of these pilots were pilots who regularly flew actual flights, and some were pilots who flew fewer regular flights. In other words, in the airline industry, you can take a job that puts you in a simulator where you fly simulator every day and train people and test people, but then you fly the line maybe once or twice a month, right? So they found that the pilots who were flying the line, or meaning that they were flying every day or most of the days of the month in an actual airplane, they had lower heart rate variabilities. Here's the big picture data for the GAM model. I'll break it down a little bit so you can see it better. So you can see age. So the three categories of heart rate variability across the top. You can see trends with age. You can see trends with BMI here as compared with a baseline BMI of obese. You had higher heart rate variabilities in the other categories. Same with age. And regular flight 65 hours a month. And then you can see a trend there. And here is the difficulty of the maneuver. But you notice there's some of the values with p-values that are less than 0.05, and some of them are not. You can see the difficulty level of C has a lower p-value. That may be due to the fact that most of the maneuvers were in this category. They were more difficult maneuvers. And so just sheer numbers helps make that statistically significant. So yeah, there's a few trends and a few associations, but it's not a perfect model. Relationship between the difficulty of the measure and heart rate variability wasn't consistent, but you did see some areas where it did make sense that the two were associated. And again, it may be because A and B maneuvers had small sample sizes. And lastly, the relationship between heart rate variability and carbon dioxide was not significant. So to me, that says that those two variables are not interacting in this model. And so there's no sort of interplay there. And I think that was one of the purposes that they did this study this way, with the carbon dioxide and adding on the heart rate variability, to see what changes there were in the heart rate variability, but also like are the two together interacting to affect pilot performance. And by the way, the CO2 levels that they were using, even if you remember from our like industrial hygiene stuff, I think like 500 to 1,000 range is pretty normal for indoor type of stuff. These were at 2,500, which is it's higher, but it's not necessarily like imminent to life type of thing. Here's some more results from the GAM model. What I want to point out here is these bottom lines. The odds ratio of passing a maneuver between A and C is shown right here. 1 is 0.63 and 0.24. And the p-value is in the C maneuver is statistically significant. But what I thought was interesting is if we look at the other models, those odds ratios were consistent between all the different modalities of measuring heart rate variability. So you had on this one, it was 0.63 to 0.24, 0.64 to 0.24, and then 0.64 to 0.23. I'm not 100% sure how meaningful that is, but when I see something that's consistent across those three variables like that, it makes me think that there's probably some sort of a correlation or consistency that helps us define that relationship. So in conclusion, heart rate variability has an association with airline pilot performance. In some of the measures, it did not meet statistical significance. We know that heart rate variability is a measure for stress. We know that heart rate variability can influence the frontal lobe and the executive functioning activity of our brains. So theoretically, higher heart rate variability could make a pilot a better pilot. But they did bring up an interesting question, and that was, what about the non-executive function activities that a pilot has to do? So a pilot may be placed in an emergency situation where they depend less on the thinking and human side of the brain and more on the instinctual and act now type of functions of the brain. And they illustrated that referencing a study where they took these subjects and they had them perform a certain test. I don't know if it was a paper test or some sort of mechanical test, but they threatened them with an electric shock to the hand. And so that higher increased stress caused lower heart rate variability, and they performed better on the response times for those tests. So that's an interesting question they brought up. So here's what I ascertained is the strengths and weaknesses of the study. So it was a pretty well-defined study, pretty decent statistical analysis with some complex methods. They used two variables that were pretty well established in the literature as far as ways to measure heart rate variability. One was not as measured, but I think one of the purposes was maybe to validate that measure a little bit more. They didn't specifically talk about that too much. They did talk about a dose response that probably could have been hit better if they had more numbers. And they controlled for multiple confounders. The sample size was decent for an experimental study design. And the environment was pretty well controlled, in my opinion. I put pilots worked in teams for realistic scenarios. When pilots fly in a commercial airline, they work together, and that's realistic. That's how they would typically do it. But I also put it over here on the weaknesses, and I'll talk a little bit about that too. So the first weakness I noticed was that the baseline heart rate variabilities may not have been comparable to the normative values because the pilots were in a situation where they were already stressed. Next, the simulated flights, they give different stresses onto a pilot. Like a pilot has more stress for passing the test than he does for imminent death, right? So it's a different stress. There is a stress there. Whether we can associate those two, it's hard to say. There may be some bias there. Most of the exams were performed by one FAA examiner. So there could be some selection or interpretation bias there, depending on, if that examiner was a hard grader or not as hard a grader. And then the fact that there's only 3 of them. And I don't know, I didn't see any information about inter-rater reliability type stuff either. So that could be a weakness. So the simulator rides were all done hand flying the airplane, which is not the same as when a pilot actually flies a flight. He'll do the first 10 minutes and then put it on autopilot and like have some popcorn or whatever, right? So the stress level is different to begin with because they're controlling the airplane and having to multitask while doing other things and thinking. So that could have introduced a little bit of bias. Like we talked about earlier, it might not be generalizable to all pilots with a 100% male group of people that maybe you couldn't compare that to a female pilot. And then I put down here interquartile statistics methods. I don't know that it's a weakness, but I think it's a pretty strong statistical method, especially if you're using a GAM type model. But I just threw it in there just because it caught my eye and made me think, well, if they're using that interquartile method, there must mean there's some outlier somewhere that they're trying to control for. And so what does that mean, and where do those outliers fit, and should they have included them, and a couple other questions that just came up. And we saw by the graphs there were a couple of those outliers just based on the difficulty of maneuver and the numbers that they had. And then pilots working in teams, even though it's a strength, also could be considered a weakness or introduce some bias, just because if you have like a top-notch pilot who's paired with a weaker pilot as far as the maneuvers, there could be like the good pilot can make up for the bad pilot, and the scores on the tests could be influenced by that. And so you're introducing another factor in there besides the heart rate variability and the CO2 levels that might influence that decision. So, all right, a couple of questions for you guys to think about. If you have any inputs to these, please certainly bring it up. So is it a good measure of pilot performance? We know that it's a good measure of stress, but what does it mean as far as being able to tell if a pilot or any other profession for that matter is good at what they do or should be prioritized in the hiring process or whatever that might be? Because there's a lot of other factors that come into it. Limitations of the heart rate variability. You can think of any of those. One thing I can think of right off the bat is, that can be heart rate variability can vary with people who have certain medical conditions. If you have AFib or something like that, certainly it's going to change your heart rate variability. And then weight loss. Is there a practical implication for using heart rate variability and weight loss to improve population health? And a little more controversial, could this be used as a pre-hire or medical screening tool? Because these pilots go through a very rigorous medical screening and this is a medical metric, could this be something that they use to as a pre-hire metric to say whether a pilot meets medical criteria to fly or not, and then ethical concerns associated with that? Anybody have any thoughts on any of those or other ideas that they thought of during that? Micah?
They're in, well, you sort of come from this world, right? Like dealing with code and stuff. Like, could information or studies like this promote use of beta blockers or anything? Like, could the information help lead to like performance enhancing things for people who are in the field already?
Yeah, that's a great question. Like, if someone has a high heart rate or high stress level, high heart rate variability, would they on their own turn to that to use that? What you're talking about?
That portion of it, maybe it could be more of like an identification or screening, like, oh, hey, this is a challenge for you. You could consider, you know, here are some things we could help you consider as you're going through, you know, whatever the training is.
Yeah, I know that we, from personal experience, that we give pilots medicines to enhance their performance already. So this wouldn't be a far stretch to say, okay, how can we make you a better pilot, right? And if we're talking about a video game or a sports competition, that's one thing. But if we have pilots who are military pilots who are overseas doing stuff that, you know, is that justifiable? That's an interesting ethical question too. So, Barry.
I just want to know, like, what's the difference between heart rate variability, which is, of course, I mean, if I understood correctly, that's a good thing, and then arrhythmia, which is bad.
Yeah.
What's
Yeah,
the
great question. So smaller amounts of variability in the heart rate, like if you have an arrhythmia, you're going to see the magnitude of difference between heartbeats is going to be more. And in addition to that, depending on the scenario and the health of the patients, they're going to have symptoms a lot of times. Now, there's some arrhythmias that are asymptomatic, but those are generally not heart rate variability related. But yeah, good question. Joe, Dr. Al.
Yeah, I have a lot of problems with this study, and it's not in the way that they necessarily measure heart rate or anything specific about that. Is that there's this giant black box that they completely ignore, which could explain away everything that they are claiming, and that's the human, like the brain, the cognition, so one thing that could blow it up entirely is practice effects, right? You saw that we have some of the hard ones that were higher variability of heart rate, and you saw a bunch that were lower. I'm guessing that the ones that were lower and had that trend towards lower were ones that they'd practiced more. They'd done those before. They'd done them 100 times before. They'd done them 1,000 times before. But the ones that were harder, they're like, I did that one a while ago, but I wasn't really good at it. Right? So your own experience of what is stressful and what's not stressful is going to affect that heart rate, right? The fight or flight response is going to take into consideration here. Those 30% of the pilots who were lower in experience probably were pulling those harder tasks up because they were less familiar with them, right? But they don't even take that into consideration. I love that you brought up the team dynamic, right? Because that's another dynamic. You're now in a team. And you have certain strengths, and your partner there, has certain strengths, and you have certain ways and so forth. And so we know from team performance literature that the team performance is oftentimes an average of the group performance, which the high performers pulling up the lower averages to meet them closer to the higher average, and to their higher performance. So these are just general human dynamics and human capabilities that are completely ignored by this, and not even really, that I can tell, not really even discussed in the discussion section. So for me, I understand the different discipline, different approach, different group. I get it, but that's why interdisciplinary research is so important. That's why us talking to each other about these things, right? Maybe in the industrial hygienist in the room might be thinking, you got to have CO2s at 5,000 parts per million before it affects anything. Right? I don't know what the number is, but I don't know if they even got to the point where it would affect the person, right? I mean, and since it's simulators, you could do that, I guess, right? As long as you're not going to hurt anyone, right? So anyway, so I had those problems. So I guess the question for me would be, what could they have added? Do you think, or others think, to address some of these issues with not measuring some of these things? Yeah.
Like a pretty quick or easy one would just be putting another variable in for years of experience.
Yeah. Well, they did have hours, those who had 65 plus hours and those who had, 65 or less hours in the cockpit.
I wonder if they define that like how long they've been doing 65 hours a month.
Yeah, I didn't see
Yeah.
that they had, but.
What about like overall fitness level? Because heart rate variability is related to fitness.
Oh,
And
yeah.
So in the concluding statement, they talked about low HRV was associated with age, high BMI, and performance. Could they just all been younger and fitter? Is why they had better heart rate variabilities compared to some of them.
Yeah, great points. I think the model sort of controls for some of those things. And you can use the BMI as sort of a surrogate for like the overall fitness level. But the human levels, I totally agree with. Like there's some things that I'm not sure I can think of ways to control for some of those. And some of those are important because those maneuvers that they're less practiced in, for example, may be the maneuver that comes up on an actual flight, right? So there's some comparability there that I think is important, but it's hard to analyze statistically that way when you have those problems.
The generalized additive mix, not in the time we have. But we can talk afterwards, Mike. He asked if I would explain the general additive mixed methods model thing. But it's not something that we can cover right now.
Yeah, I didn't talk about it much because we didn't have time and also because I'm not sure I understood it that well.
Yeah, so I would not, if you're thinking about doing an analysis, I would not go that route or use those words to describe it. Just throwing it out there. But yeah. It's really multiple regression with multiple controls, which is what it is, but they're trying to make it sound more exciting than it is. So.
I was too naive to recognize that.
Sorry.
You're okay.
You guys hear me now? Hello. Okay. So my name is Mubo, and I'm a second-year student in OIP, and I will be discussing this article, the 5-year outcomes in a cohort study of physicians treated for substance use disorders in the US. Whew. Okay. So, just a little bit of the background. The PHP, also called the Professional Health Program, is a confidential resource for healthcare workers, including people in training for addictive, psychiatric, medical, behavioral, or other potentially impairing conditions. So the major aim of the PHP is to reduce public health problems caused by impaired physicians. And impairment, by definition of the PHP, is just restricted to addiction and mental health issues. And they do this through early detection, treatment, and monitoring of substance use and other health problems. So the PHP is usually either affiliated to the state medical board or is controlled by one. So there's differences according to states, but they're usually close together in a relationship. So this is how the PHP works. So if a person is referred to the PHP, either through a colleague or a superior or the hospital board where they work, the PHP then conducts a comprehensive assessment, and then the PHP recommends a treatment plan. So the PHP doesn't actually treat these people. They just recommend treatment for them. But if the physician refuses to comply, the physician would then be reported to the state medical board, and then they would face potential disciplinary action. But if they do comply, they would have to do whatever rehab or treatment is recommended by the PHP. And then the PHP then does monitoring. So that's where they come in. Okay, in terms of the disciplinary action, they could have limited practice, their licenses could be suspended, they could place the physician's name in a national monitoring book, they could restrict the license to limit prescription of some substances depending on what they were addicted to, or in extreme cases, they could revoke the person's medical license. So even though they say the program is voluntary, it's really not, because there's a lot of penalties associated with not doing it. Okay, so for this study, it was a retrospective longitudinal cohort study, and they selected 16 PHP programs in the, I made a mistake, in the United States. Okay, and they had to do a study beforehand. They used all 49 active PHP programs here, and then they just evaluated the program in terms of content, what they do, and how people are referred and stuff. So they selected the 16 PHP sites based on size. I mean, size of participants and not like the building and stuff. And the sample size was 904. So they used only physicians in this study and not nurses and other healthcare workers. And they used people who were in the program between 1995 to 2001. And the selection criteria for the study sites was availability of electronic records on alcohol and drug testing, and the ability to retrieve this kind of data from their records, so demographic, treatment, and outcomes. And the study was done between November 2006 to January 2007. Okay, so the outcome measures for this study was program completion, continued alcohol and drug misuse, and then the occupational status at 5 years. Okay, so these were the participants' characteristics. The average age was 44 years. It was 87% male, 63% were married, 18% divorced. And then in terms of medical specialty, most people that were addicted to any kind of substance were in family medicine, and it was followed by people in internal medicine, and the list was in psychiatry. And the abuse problem, in terms of substance of choice, it was mostly alcohol, and then opioids before stimulants, and then people had a combination of abuse, including combination of alcohol and opiates or alcohol and stimulants, and then 13.9% had a history of intravenous use. So the average substance use was more than 5 years. So that was like average use before the start of the program. And then 17% had been arrested for alcohol or drug related offense, and 50% were formally mandated to join the PHP. And that was through their jobs, I think. Okay, so for the treatment, this is the part where the PHP recommends them for something external. So the PHP doesn't have any role in this part. So most people in this study did residential treatment, and the average was 72 days. And it was usually followed by an outpatient treatment for 1 to 3 nights a week for 6 to 9 months. And they all had to do the 12-step treatment, including Alcoholics Anonymous. So most people were eligible to return to work after 6 months, but obviously that will be with positive results and good compliance. And some people had to do pharmacotherapy and were given antidepressants. So 78% of people in this study had to do residential treatment, and 22% had to do outpatient treatment. So this directly to outpatient treatment. So these differences, it just reflects the differences between a person who has an addiction issue and a person who just had a bad day. So there are people who obviously have to do residential treatment because they have an addiction issue, as compared to somebody who just had a bad day, drank too much, had a DUI. They still have to do this program, but they don't have to go to rehab. Okay, and sorry. So in terms of the follow-up, this is where the PHP comes in. So they do all of the monitoring after the rehab ends or outpatient treatment, whichever one they have to do. So they mostly do drug testing for with urine, but some people do saliva, hair, and I think breath as well. And testing is done 4 times a week. No, sorry, that's ridiculous. So 4 times a month, and then it's tapered off. So it's tapered off based on positive results and how well they progress, obviously. And 75% of the urine was collected through direct observation of the staff or in dry rooms, just to ensure that the urine samples were not compromised in any way. And the testing panel used in all of these PHPs covers 20 substances. So I thought this was interesting because the typical one for the general public only covers 5. So this one has both prescription drugs and even cocaine and other kind of drugs. I couldn't list everything here. And participants are also expected to attend appointments for clinical evaluations. So participants are literally supposed to call the PHP every day to find out if they have to do a test or not, which is so hectic. And then they also have to go through random unannounced visits at their workplaces. Okay, in terms of the results, so they used 904 physicians admitted via all 16 PHPs. There were 102 physicians lost to follow-up. So they had 78 transfers and 24 who moved away without informing the PHP, sorry. So all 102 physicians have to automatically be reported to the medical state board, but nobody knows what the state board decided. Okay, and in terms of the monitoring status within 5 years, there was 155 people who failed, and then 647 who completed their treatment. So let's start with the left side. So of the people who failed, there were 85 people who voluntarily quit clinical practice. And this was fueled by advanced age and the cost of treatment as well. Because in the PHP, there's rehab, and then there's the monitoring with all of those tests. And these physicians are expected to fund that themselves. Some of them do have access to health insurance, but a lot of it is out of pocket. So there are some people who are just not able to afford this kind of treatment. At the time the study was done, it was about $40,000 for the 5 years. And then there were 22 deaths, 6 of which were suicide, and then 48 licenses were revoked. And that was purely based on very severe addiction with no positive progress. And for the 647 people who completed the treatment, we had 515 who did that in the contracted period. So if their treatment was 6 months, they did that without any relapse. And then there was 132 that had extended monitoring. So 126 out of that misused different substances. 33 had repeat positive. And I think the author mentioned that of this 132 people who had extended monitoring, 10% had relapses while at work. So they had finished their treatment and gone back to work, and then they were caught abusing substances while on call. So in terms of occupational status, at the 5-year mark, there were 631 people who were licensed without restrictions. 87 licenses in all were revoked. Additional 28 people retired or left voluntarily. There were 30 deaths, 7 of which were overdose related, 6 were suicides, and then other causes, and then 26 people with unknown status because their data was missing. So this study doesn't have any interesting statistics, but it does have tables on page 3 and 4 in case these ones are not clear enough. So this one is just a summary of what I already described, which is the occupational status at the 5-year mark. And then the table on my right is the result of the drug test for people who actually completed the program. So they just split them up into two groups. So people who completed it in their actual time frame, and then people who had to do an extended monitoring. Obviously, people with extended monitoring had higher numbers of drug tests and things like that. So that is no surprise whatsoever. Okay, the conclusion of this study was that the combination of rehab and monitoring is effective in rehabilitating most addicted physicians. And the authors based this off the fact that 3/4 of people in the program actually finished the treatment and returned to work without any restrictions in their licenses. So in terms of the strengths and weaknesses, I thought the study was very clear and the methods were reproducible. So anybody can go through this and attempt to repeat the study. The sample size was large. And in terms of the weaknesses, the sample may not be considered nationally representative because they used only 16 study sites out of 49 available in the country. And the study type as well, because it's a secondary, because they use secondary data, they don't really have control over the content of what they received. And another issue with the data collection method is there's just a lot of confidentiality around the physician health program. So the authors were not able to collect that data themselves from the records. So they had to train staff of the PHP that worked in medical record to extract that data from them, and then they just collated it. The last point is not really a weakness, but I would have loved to see more information about other health professionals in the program, like the differences between physicians and nurses. Are there differences in the kind of substances they abuse, or are there differences in how each group finishes their treatment? You know, do you have nurses doing better than doctors and things like that? And then maybe even in terms of how they are funded, because they said some people do receive support through insurance programs. Do you have more doctors receiving support as compared to nurses? You know, I would have just loved to see more information about other groups in the physician health program. And I think that's it. Any questions? It was all clear.
About the article, statements about it? Bad ideas?
One question I had was, so there were the 7 overdose deaths and the 6 suicide deaths. Could some of those deaths have been counted in each category, or were they separate categories? And if so, were some of those suicides due to their previous addictions? Like, obviously, there's probably not the information. that they
Yeah.
haven't, but
I don't know. I
Just
think
a
the
general
fact
thought.
that they mentioned suicide separately and OD, I don't think it was the same. I think it was accidental overdose in the people who had overdose deaths, and then suicides for suicides. I don't think, you know, they mix it up. I'm not sure.
do you have any idea which PHP programs are the biggest? Or are the 16 all out of one region of the country, or are they kind of spread around the country?
Yeah, so that was the biggest issue I had. They didn't specify what regions they selected the PHPs from, but they did mention that they selected the biggest ones. I know around here, Utah is one of the smallest ones. They have like 20 participants per year. But if you go to places like Florida, they have like 750 participants per year. So I just don't know where they pick people from.
Interesting, because physicians seem to get this like special treatment of a monitoring program, and there are other occupations, of course, that have issues with substance abuse. So I'd be interested to see if like the point of this study, like, could this be applied to other occupations? Is it successful, or is there something special or specific about physicians that makes this so effective?
Yeah, that would be great to see as well.
Very good point. And one of the decision points on any intervention is cost benefit analysis, which sounds terrible to say when you're talking about addiction and opioids. But the reality is, you know, what's the benefit of this sort of very intense intervention for other types of occupations, right? With a physician and malpractice and errors and stuff like that, it's very salient to people what the benefits are for helping someone, recover and overcome addiction in that context. But maybe it's not quite as obvious for truck drivers or line workers at Google. Just kidding, Google doesn't have a line. But anyway, other types of occupations, this may be a cost prohibitive thing because we either don't see them as needing that kind of attention, or the risk for a bad outcome is so much less for that occupation than it is for another occupation. So we don't put the resources behind that, even though it may be extremely effective in other places. So it's the truth about, or the dirty truth about interventions, that may be very, very helpful for the person.
Well, they have the same thing for lawyers, pilots, and veterans at the moment I know of. But I don't know about people in construction or manufacturing. No idea.
Positions.
So I guess the other question for me would be, if we tried to do those other positions.
Yeah.
What reason would they have to do the program instead of just jumping ship into another lower wage profession?
Yeah.
For like a
Right.
position, you lose your license, a lawyer, you lose your license, a pilot, you lose your license.
Uh-huh.
You no longer could do your high paying job. For a construction worker, you just join another construction company.
Yeah.
So like, it makes it harder to do for.
Yeah, the
other jobs.
consequences aren't strict enough, if you want to call it that, for these other occupations, right? But also we would never, sadly, put the resources behind, getting them even if they wanted to, they personally probably don't have the resources to enroll in one of these, and to pay for it themselves. And their employer is definitely not going to.
Just a curiosity, in the body of literature, do you know if there's been any further studies, or, it sounds like the programs are still around, but like, did anybody else take another step past this study? Once
Yeah.
it's done, or-
So they've done like 5 more, the same authors actually, and they actually just did program specific. So like they did family medicine alone. I think they did one for physicians and anesthesia, but they've only just focused on physicians and not every other healthcare worker. Yeah.
The single rank.
Yeah.
And just out of curiosity, what made you interested in this article or this field?
Well, I actually want to do my dissertation in the physician health program. Yes, and I will be repeating the same study, but just in Utah, because it wasn't part of the original research. And then I plan to compare the findings from Utah to what they have here, because I know Utah has a lot of restrictions, alcohol and stuff, and then there's a lot of stigma attached to substance use here. So I spoke to one of the program managers in Utah, and she mentioned how if a physician is abusing substances here, they'd rather go to another state to get their treatment done. So it's not like they don't have enough data, but people just don't want to be treated where they live, so that's another thing. And it's a very religious state as well, so yeah. Yes, it's going to be the same retrospective, but not the same time frame, obviously. I'll use more current data. Yes, Uchi.
Missed this, but was there any data about the difference between subdisciplines, like about how well this program worked for family medicine?
Sorry, can you see that again?
Was there like any data about the different subdisciplines of physicians, like how well this program works for somebody who does family medicine versus surgery versus emergency medicine, maybe?
It was just whether it worked or not. Yeah, so they didn't, the only time they specified the different programs was when they were given the patient's characteristics here, like the groups, but it doesn't say how well people in each of these programs performed. So, yeah.
Maybe it's more applicable for the higher intensity departments like emergency or internal med versus not medicine, maybe something geriatric medicine.
I mean, it sounds like they have the information to be able to do that. Their sample size may or may not, I mean, if it's 20% family medicine, I forget the sample, it's
907.
907, so 20%, that's 180, right? So that's a big enough, I think 7% might be a little small, but they're large enough groups that you could at least take a look at it. So, you know, maybe that's one of the other 5 papers they've written,
Yeah.
but mining the same data set for a half a dozen papers, that's nice.